Hello, ladies and gentlemen. Can everyone hear me? So I'm Linda Mantia with the Board of Directors here at Sunnybrook, and I am very happy to welcome you to the first lecture of 2021. I think many of us were ready to see a symbolic fresh start with the turn of the calendar. While there's still a long road ahead of us, the past few months, as you know, have been especially challenging. The pandemic has many of us living differently, moving differently, and working very differently. For some, those changes may mean the start of or worsening of existing neck and back issues. We know that millions live with some form of pain or reduced mobility due to neck and back issues. These leading causes of disability prevent many people from engaging in work and being able to enjoy activities of daily living. We are especially fortunate this evening to have an esteemed panel of experts with us. They will be discussing a wide spectrum of back health topics. As you may know, we had originally planned to do this talk in early 2020, but the pandemic caused us to shift course. There was a tremendous amount of interest in this topic, so we are very pleased to be able to bring this lecture to you this evening. As always, the speaker series is a wonderful way to engage you, our patients and community, in relevant and timely health issues. We hope you find tonight's discussion to be meaningful. So now, to begin, I would like to introduce tonight's moderator, Dr. Albert Yee. Dr. Yee is chair in the Division of Orthopedics here at Sunnybrook Health Sciences Center. Dr. Yee is also an associate scientist with the Sunnybrook Research Institute, with a focus on potential new therapies for the treatment of spinal disorders, among other areas. We are very lucky to have him here to lead us through tonight's discussions. So I'll now pass the microphone over to you, Dr. Yee.
Thank you so much, Linda, good evening and welcome everyone. I just wanted first and foremost really to acknowledge Linda and the board for your very strong support of our speakers series. And I think as alluded to, basically we are here to focus on the topic relating to back health. And this topic, as Linda's mentioned, was originally scheduled in person in March. And I'm glad that we've been able to organize ourselves to provide that session this evening virtually. So this topic, I think, is fairly prevalent in our society, and I do hope that everyone is continuing to keep well and safe during this period of time. And certainly at Sunnybrook, we recognize the ongoing need to really provide health for all conditions in the healthcare field as we continue at the same time to fight the pandemic. We have assembled a variety of speakers, and I do need to acknowledge and thank in particular Dr. Joel Finkelstein. He's the Division Chief of Spine Surgery and the Feldberg Chair in Spinal Research at our hospital, and an Associate Professor at the University of Toronto. He's done the lion's share of the work in terms of organizing the panelists and speakers for this evening. My role here is really to moderate the sessions and the question and answer period that will follow. And so we'll hear from him as it relates to the anatomy of the painful back. We also have Ms. Maria Rakovic, who is a practice lead and advanced practice physiotherapist as part of the Rapid Access Clinic here at Sunnybrook. So thank you, Maria, for your time this evening. And we also have Dr. Philip Palmer, who is a chiropractor, director of the Genesis Rehabilitation and Sports Injury Clinic in Toronto and Vaughan. So between Maria and Philip, we're going to hear a fair bit about non-surgical treatment options that may be helpful for individuals that do have symptoms arising from the back or the spine. And Dr. Jeremy LaRouche is a spine surgeon, assistant professor at the University of Toronto, and will cover surgery as it relates to common low back conditions sort of when necessary. I guess as I sort of turn the virtual podium over to Dr. Finkelstein for the first presentation, we have received questions ahead of time, so thank you to the community, our friends and colleagues who have provided these questions in advance. We've collated some of the questions from both the questions that were submitted for the March session as well as for this evening. So I'll sort of look through and organize those questions from a thematic sort of perspective to cover as much of the topics as much as possible. We may not be able to get through every single question, and obviously there are some questions that are very individualized, which may be more beneficial to sort of a direct healthcare provider, sort of a patient evaluation more specifically. For questions that may arise during the course of this evening, please, there should be a chat function in the web link that you have been provided to connect to our session this evening. And at this time, I'll turn things over to Dr. Finkelstein for his first presentation. So thank you, Dr. Finkelstein.
Thank you, Albert, and thank you to everyone for putting this together. And I know it's been a long time in the making. We tried to do this several months ago. It didn't quite work, but we're going to make it work now, and I think it'll be a very informative session. So really my talk is an introductory talk, which is going to put into focus all the options available. Then we'll have the various speakers give their insights and what their expertise is and their experience in their various roles. So this is really anatomy of a painful back and a primer to understanding back pain. So, particularly during this COVID pandemic, we're all sitting in our homes and we're not getting as much exercise, and back pain is quite prevalent. In fact, even without this past year, there's a 90% prevalence of getting back pain sometime during your life. The majority of these episodes of low back pain, though, do not seriously incapacitate people. 50% of these acute episodes improve within a week, 90% improve within a month, regardless of whatever treatment is administered, and about 7% of low back pain lasts and becomes more of a chronic nature. We've all heard the term degenerative disc disease. Well, degenerative disc disease isn't really a disease. It's just age-related degeneration that happens to everybody's back or their discs. And I illustrate here a picture of what a normal disc would look like. It's nice and plump. It has good height. It's very mobile. And here's a cross-sectional view of the disc. But then as they degenerate, the disc will develop these little lines in it or fissures. They lose their hydration. They become more stiff. And you see how they have these little cracks or fissures in them. So this is a normal looking disc and a degenerative disc. Kirkcaldy-Willis talked about the 3 phases of degeneration of discs, of disc degeneration. The dysfunctional phase, as you can see, moves on to the unstable phase and you get more loss of height. And then as time goes on, even though it's unstable and there's more degeneration, it then restabilizes. And in fact, as you get older, there may be a phase where back pain gets worse, but as it restabilizes, in fact, the back pain can get better because whatever motion is at that disc space or that vertebral segment, that motion is lost. And whatever motion there was, it was painful motion. So as it restabilizes, the pain can often get better in the long run. But during the time that someone does have a painful back, identifying the pain generator is not an easy task. There's been a lot of misidentification of what is actually causing the pain, whether it's the disc, the muscle, the facet joint, or the nerve root. And if you can't identify the source of the pain, it's hard to treat. So just because this is a degenerative disc, is this disc painful? Well, in fact, identifying the pain generator is really an industry to itself. We have X-rays, CT scans, MRI scans, and discograms. These are all various techniques or imaging modalities that we've used to try to identify the source of pain or the painful disc. But do x-rays lie? Well, many spine abnormalities are as common in an asymptomatic person as those with patients with pain. This is a narrow disc at the L5-S1, but this, in fact, this person has no pain. This again is a loss of the L4-5 disc space height. There's sclerosis at the end plates, all findings of degeneration. There's little bone spurs, but there's no clear correlation between degenerative changes and pain. MRI scans have much greater sensitivity, but oftentimes the abnormalities that are seen on the MRI may have no clinical significance. The MRI has increased the sensitivity of finding these quote unquote abnormalities. Some of these non-specific findings are a black disc, one that has lost the hydration compared to the one below, bulging discs and protrusions, which are often read and reported and are seen, and these are often just incidental findings. These same changes are seen with and without back pain. In 1990, this was a study by Bowden, who noted that degeneration and bulging of discs occurred in patients, in basically all people, and in the vast majority of patients, they had no symptoms, but they had these abnormalities on the MRI scans, again, showing that these were simply incidental. Further study in 1994 again showed that on MRI examination of the lumbar spine, many people without back pain have disc bulges or protrusions. And given the high prevalence of these findings, you have to be careful in trying to equate or say that A is a cause of B. Discography is another test that is used where injection of contrast is put into the disc space, and the physician has to interpret whether there is enough resistance of the disc, and they has to report on the patient's subjective pain during the injection. So a painful injection would be suggestive of a disc that is a source of pain. But there was very little correlation between discography and MRI. In fact, many patients who've had positive discographies had normal MRIs, and then patients with abnormal MRIs may have had normal discograms. So there was very little correlation between those two studies. So again, in this study, there was found to be many MRI abnormalities present in asymptomatic and symptomatic patients. But what they found was that work attitudes and oftentimes psychosocial factors often predicted symptomatic versus the asymptomatic disc herniation. So treatment of back pain has become an industry just like the identification of back pain. So there are many treatments for back pain. Some are efficacious and some are not. We can break down these treatments into conservative or non-invasive treatments, non-surgical or semi-invasive treatments, and then surgical or more invasive treatments. And the next few talks will talk about each of these different choices. The non-invasive treatment for back pain is things such as chiropractic, physiotherapy, massage, TENS treatment, ultrasound, exercise, and weight loss. Semi-invasive treatments are things such as epidural blocks or facet joint injections. Selective nerve root blocks such as transforaminal injections can also be used when there's more of a leg component to the pain. And finally, surgery can be used for back pain. So this takes me to one of the peer-reviewed journals, the Wall Street Journal, and this was an article written in the year 2000 by an investigative journalist, Lisa Gubernick, who entitled it, Have I Got a Cure for You? And asked the question, how many doctors does it take to cure a common ailment such as back pain? So she took her back pain to 8 different specialists and got 8 different diagnoses and 8 different treatment options. She went to an osteopath and had a diagnosis of sacroiliitis and was recommended she have naproxen and ultrasound. Went to a chiropractor and diagnosed possible facet impingement and recommended physical therapy. An acupuncturist, you guess it, recommended acupuncture. Psychiatrist had no formal diagnosis but suggested Valium. Homeopath suggested there was no specific diagnosis but recommended some chalky tasting pills. And then the physiatrist, the neurologist, and finally there was a celebrity doctor at that time, John Sarno, who recommended to buy his book and his lecture series at a cost of $800. So really, she called this the hammer and nail syndrome. A further article by Jerome Groopman in the New Yorker magazine in 2002 looked at the question of chronic back pain and felt and recognized that if imaging was so imprecise and non-specific and the ability to identify the pain generator was difficult, then how can surgery be effective for this? And why are there so many ways to treat back pain? So his article is entitled "A Knife in the Back" and questioned, is surgery the best approach for chronic back pain? There was a huge rise in back pain surgery and fusion surgery in the United States. And this led to this article, an editorial in the New England Journal in 2004 that really called for the case for restraint in back pain surgery being fusion. So really the state of chronic back pain can be seen as, like in your case, Dave, there's a choice: elective surgery, outpatient medicinal therapy, or whatever is in the box Carol is holding. It's not quite like that because we do have better ways of diagnosing and we are more precise. But I want to differentiate back pain from leg pain. Leg pain is a very different issue than back pain. Leg pain is due to neurologic compression, such as a disc herniation. It leads to things, or what we call sciatica or radiculopathy. And another cause of back pain is spinal stenosis. So here is sciatica due to a disc herniation. And this is an example of a disc herniation. And then here's a case of spinal stenosis where there is narrowing of the spinal canal leading to compression of all the nerves, and you have the feeling of numbness and weakness and pain in your legs that occur when you walk and gets better when you sit down. And leg pain is a very different issue than back pain, and that is a very good case for spinal surgery. Again, an example of spinal stenosis. So treatment for leg pain, surgery is very reliable, has much greater efficacy than surgery is for back pain. And here we decompress the nerve root, such as a discectomy or a laminectomy. Here's an example of an approach for surgery. We often use a microscope. This is an example of spinal stenosis with narrowing of the canal. We do what's called a laminectomy. And from there, I'm going to pass it on to Maria, who's going to give the physiotherapy approach and talk about some of the conservative measures.
Thank you so much, Dr. Finkelstein, and appreciate that update. And I think sort of in keeping with the theme of trying to determine where pain symptoms may be arising from and how it relates to imaging, and potentially differentiating whether the pain is more localized to the back or the leg area that may have implications, at least from a clinical perspective. We'll segue over to Ms. Maria Rakovich. Susan Robards was not able to be in attendance this evening, but we certainly appreciate Maria's expertise and valued help as our practice lead as part of our rapid access clinic at Sunnybrook. And she will provide a bit of an update in terms of the assessment and management of a low back dominant pain. So thank you so much, Maria.
Thank you, Dr. E. Do you see my screen now?
can.
Yes.
Good evening. My name is Maria Rachevitz. I'm an advanced practice physiotherapist, and I work with a team of spine surgeons in Sunnybrook. Part of my role is to perform initial low back assessments and decide who needs to see a surgeon. I also help people with low back pain manage their condition better and recover quicker. And tonight, I'm going to provide you with some inside information about low back pain and dispel some common myths. My hope is that by the end of this presentation, you'll be better equipped to deal with the low back pain. Here's how I'm going to do it. First, I'll tell you about the most common type of low back pain. You probably already know that having a good assessment and an appropriate treatment is critical to a successful recovery and a great outcome. But did you know that research shows that most existing myths about low back pain actually hinder recovery and promote chronic pain? Low back pain, as Dr. Finkelstein mentioned, is very common. In fact, it is so common that it's not considered a disease, but a part of human experience. In a way, this is the price we pay for walking upright. In most people, it will go away on its own, but it's still one of the top 2 reasons people visit doctors, outnumbered only by the upper respiratory infections. Only a small proportion of people with low back pain need surgery. The majority needs only non-invasive treatment. It has been proven that the best approach to care is a team approach, where you see the right professional at the right time. I will describe in a moment how it looks like. This is just a small illustration again about that only 5 to 10% of people with low back pain need surgery, and in the remaining 90%, the back pain is only related to is not related to any serious pathology. Despite that, these people also need a thorough assessment and an expert advice. In Sunnybrook, we have a team approach to care, evidence-based team approach to care. What this means is that a lot of patients who refer to the spine clinic see the advanced practice physiotherapists first. The reason being is that most people do not need surgery. The benefits to the patients are early access to thorough assessment and an expert advice on exercise and activity modification. It's if a patient needs surgery, then he's referred for a surgical consult. The advanced practice physiotherapists and surgeons have a high level of agreement and make similar decisions about who needs surgery and who doesn't. This approach to care has been proven to be very effective, and patients are highly satisfied. We have shown that an advanced practice physiotherapist can effectively reduce wait times by 70%, reserving surgical consultations for those patients who really need it. Advanced practice physiotherapist is someone with advanced formal education and specialized training who works closely with surgeons. The most common condition I see in the spine clinic is the so-called back dominant pain. What do we mean by back dominant? This type of pain is characterized first by its location. As you can see in this diagram, the pain can be localized around the low back area, buttocks, and around the hip area. Some patients may have pain down the leg, but the pain in the back, in the above areas, is the dominant. 90% of this type of back pain is mechanical in nature. What it means is that the term mechanical means that the pain is related to movements, positions, and loads. Mechanical low back pain has the ability to respond to particular movements in a consistent manner, and this consistency in its response to movement is called directional preference. In plain language, what this means is that people with mechanical pain will get consistent relief or consistent aggravation of their pain with particular movements. For example, when they arch backwards, which is called extension, or when they bend forward, which is called flexion. This type of pain is considered benign and harmless because there is no damage to the nerves or the spinal cord and no surgery is indicated. It has a good prognosis for recovery and has a reasonable chance to resolve by itself with time. It is most often intermittent or it can be constant but is short-lived. As I mentioned earlier, mechanical low back pain has the ability to respond in a consistent manner to a particular movement, and this is called directional preference. There are three possible ways the response can go. The pain can get better, can stay the same, or become worse. And this response actually is exactly what we're interested in when we assess mechanical pain. What we look for here is to establish a pattern of clinical presentation. And now I'll show you what I mean by that. The directional preference determines the pattern of clinical presentation. To establish the directional preference, first we ask the patient to bend forward and then to arch backwards. While he's performing these movements, we ask him to report what happens to his back pain. And he has to tell us if his pain becomes better, worse, or remains unchanged. Based on his response, we make a decision which pattern his pain belongs to. There are two possible patterns of clinical presentation. Pattern one is pain is worse with bending forward, but gets better. So it's worse with bending forward, but gets better or remains unchanged when he arches backwards. This is the more common type. Pattern one is less common, is the opposite of the first one. Here the pain is worse with arching backwards, but gets better or remains unchanged when bending forward. We also perform additional tests and neurological exam to rule out some more serious conditions, but this in essence is what we look for. Once we know the pattern, we know what exercises to recommend and what advice to give. This is how the directional preference and the pattern of clinical presentation guide our treatment and recommendations. For example, maybe the most elegant aspect of this approach to assessing back pain is that it allows us to use movement to relieve the pain and treat the back. As you see in this slide, in pattern one, where pain is worse with bending forward, we'll use movement in the opposite direction, arching backwards, for pain relieving exercises, for comfort positioning, or even for core strengthening. Similarly, in pattern two, we'll do just the opposite and recommend flexion-based relieving exercises, positioning, and core strengthening. In addition to the aforementioned recommendation, a good back exercise program always contains such components as cardiovascular conditioning and stretching exercises. These are also guided by the directional preference, especially in the early stages of treatment. Same principle apply to the pattern two, and most important aspect here I want to underline is actually the third point, that hurt does not equal harm. What do we mean by that? One important aspect of the benign low back pain is that the severity of the pain, which can be excruciating at times, does not reflect the seriousness of the problem, and the vast majority of people recover within a few weeks. In this type of pain, we're not worried that something damaging is happening in the back, and our consistent message and advice is to stay active and avoid bed rest. In the early stages, the pain can be very severe, and that is why the emphasis in the early stages of the treatment is on a hands-on treatment. Massage, acupuncture, spinal manipulations, and mobilizations play an important role at this stage, but they should not continue indefinitely. Usually 8 to 10 sessions of acupuncture and spinal manipulations are sufficient. And if they don't work for you from the very beginning, there is no reason to proceed. There is no reason to persist. Based on the best practice guidelines, as time progresses, the treatment should transition from hands-on to emphasizing physical activity and movement. At these later stages, we promote active approach, and movement is the most important aspect of it, because remember, movement is treatment. Another important point that I would like you to take away from this talk is that in low back pain, we're trying to stop the cycle of pain enter into this chronic stage and prevent you from resuming your normal life. Our goal is to interrupt this cycle of pain and help you to return to your usual activities as soon as possible. Your attitudes and beliefs also affect your outcome. For example, beliefs that low back pain is extremely harmful and disabling, in combination with avoidance of movement, may set up a vicious cycle of inactivity where you become deconditioned, and this makes it even harder for you to return back to your normal or desired activities. This cycle is precisely what we're trying to interrupt through active movement and physical activity. In this regard, an early treatment for low back pain also decreases the chance that your pain may become chronic. A little bit more about pain. Current research shows that pain is more of a protective output of the brain rather than an accurate measure of how much tissue damage is happening. Pain is influenced by many factors, and many things contribute to the pain experience. For example, the pain we feel can be modified by distraction, exercise, or physical activity. Our beliefs and thoughts, as I mentioned earlier, also affect our pain experience. Evidence shows that people who hold pessimistic views about the cause and the prognosis of their low back pain have poor outcomes. A lot of people turn to mind and body type of exercises like yoga or Pilates to manage their pain. People certainly ask us about that. Both of these type of exercises address the physical and mental aspects of back pain through core strengthening, flexibility, and relaxation. Evidence shows that both of them can be recommended for people with chronic low back pain, but my recommendation for you is to look for experienced instructors in both. A word of caution, be careful with back extension in yoga if your pain comes on with bending backwards. And Pilates is effective, but not superior to any exercise, any other exercise. In summary, there is no magic wand. No particular exercise program is superior to any other based on research. The best approach is a combination of pain-relieving exercises, positioning, stretching, core strengthening, and general aerobic conditioning. Another question we get very often is, should I have an MRI, CT scan, or X-ray for back dominant pain? You heard a lot of reasons why that's not appropriate with Dr. Finkelstein. And I just mention 2 points. Imaging is not useful in people with benign back dominant pain, mainly because the findings are not specific and they do not guide our treatment. Approximately 90% of back pain cases, we're unable to identify a specific structure that generates the pain, And even if we were able to pinpoint the exact structure causing your pain, this wouldn't change our treatment. The structure generating the pain in a benign back dominant pain doesn't guide our treatment decision. It is the pattern of clinical presentation that does. If it's not useful, what is the harm? It usually takes us down the road of unnecessary assessments, investigations, which are costly, time-consuming, and they do not only change the do not change the outcome, but create unnecessary anxiety and fear in patients, because at above the age of 50, nearly 2/3 of people without back will show some degenerative changes, even if they don't have back pain. That said, there are other types of back pain when imaging is absolute necessity, and there are some situations when back pain can be worrisome and then imaging is necessary. Here are the symptoms of concern that suggest serious as opposed to benign causes of back pain. We call these red flags, and they require further investigations and additional tests. The first one is about sudden change in your bowel and or bladder control, and numbness or numbness around your groin and rectal area. This usually makes us think there is something that might be pressing on the spinal nerves there. The second red flag is about infection as a cause for your back pain. If you have persistent fever, chills, back pain, and you're at high risk for infections because of a weakened immune system, diabetes, or IV drug use. The third red flag is about the risk of fracture in the low back, and it is in the situations when your pain starts with a big fall after a car accident, or maybe you are at a higher risk of fractures because of osteoporosis and brittle bones. The fourth one is about cancer, the cause for back pain. Usually a history of cancer, especially of the breast, prostate, and lungs, combined with constant pain at night, even when you're lying down, long-lasting, and unexplained weight loss, are reasons for you to consider follow-up with your doctor. The fifth red flag is about diseases that can cause a lot of inflammation of the back. One of them is ankylosing spondylitis, which is rare and usually starts at younger age. These patients have night pain, long-lasting morning stiffness, usually more than an hour, and their pain feels worse with rest but improves with movement. While low back pain is a common problem and can be disabling at times, here is the good news. Most episodes resolve in a few weeks. The most common type is what we call mechanical and is not due to a serious condition. Systemic disease is rare, about 10%, and malignancy is even rare as a cause of pain, of back pain. There are specific clues that help us suspect serious disease as a cause of low back pain, and a thorough assessment will reveal that there is a more serious condition as the cause. The main message here is to remain active and avoid unnecessary tests and treatments. Remember, exercise is medicine. And of course, I wouldn't leave you without mentioning COVID. Statistics shows that COVID lifestyle has increased sitting by 28% a day and decreased physical activity by 33% per week. Find ways to sit less and move more, and don't forget, sitting is the new smoking. In wrapping up, I'll try to dispel some myths, and I'll leave you with a final point. Myth number 1, my pain is terrible, it must be something bad causing damage. The fact is, hurt doesn't equal harm. Myth number 2, nothing has worked, so I need surgery. The fact is, surgery is beneficial for leg dominant, but is not beneficial for back dominant pain. Myth number 3, moving will make my pain worse. Movement actually reduces pain. My back pain hurts so much, I need to rest in bed. Action comes before improvement. Physical activity and work is part of the cure rather than something to wait for until you're cured. Myth number 5, my back is out. The fact is, back is strong. Back is made for movement, and exercise strengthens the back. Myth number 6, I need an MRI to see what's wrong with my back. Fact, MRI is only a benefit if there are red flags or if surgery is being considered. In conclusion, I hope this talk has helped you understand low back pain better and you make a step in the right direction. The road to recovery from low back pain is bumpy and difficult at times, but it can lead to some interesting discoveries and beautiful destinations. Thank you.
Thanks so much, Maria. I really appreciate that update. And I think you highlighted quite well the importance of physical activity as it relates not only to back health, but I think our overall mental well-being, as well as other aspects such as cardiovascular health. So I think it's a nice complement to Dr. Finkelstein's presentation that takes the importance of clinical history and examination to really determine the patterns of pain, and that there's different types of back pain that respond to different types of treatment, and often there may be a bit of a disconnect in terms of what imaging may show versus clinical symptoms, and likewise you highlighted quite well the when imaging would be necessary, recognizing that the specificity of it is obviously not fully precise in all situations. So thank you so much for that. So we'll segue to Dr. Philip Palmer, who, as I mentioned, will provide an update on the role of chiropractic care and treatment options relating to spinal related symptoms. So thank you so much, Dr. Palmer.
Thank you, Dr. Yi. It's a great honor to be here and be involved in the Integrated Spine Program talk this evening. Next slide, please. So we'll just start with a little cartoon. Here's a lady at her chiropractor. She says, the pain starts in my husband's lower back, then it travels up his spine to his neck, then it comes out his mouth and into my ears. And that's why I get these headaches. Perhaps. Next slide. So I wanted to talk a little bit about where does chiropractic fit in to this integrated spine program, and what does the evidence tell us about the clinical effectiveness of chiropractic in dealing with back pain. So when we're first injured or feel back pain or have an injury, usually the first options would be over-the-counter meds, chiropractic, physiotherapy, non-specific exercise, cycling, walking, prescription medications, yoga, massage, acupuncture, and of course, time. Now, if those don't work, option number 2 would be some type of a pain management therapy with a physiatry or a pain clinic. And thank goodness, if none of those worked, we have the option of surgery. But on average, 95% of back pain can be treated within the first 2 options. Next slide, please. So we have to remember that chiropractic is a profession. It's not a treatment. I've had people come to my clinic and say, well, I've been to a chiropractor, it didn't work. And I ask them, well, what have they done? And the patient would say, well, maybe a side-lying spinal manipulation, but there's many other treatments that chiropractors have available to them to treat back pain. So what would a typical office visit look like when at a chiropractor? So we would normally do a history and a thorough physical evaluation. We would make sure there were no red flags, which Maria in her presentation did an excellent job talking about. Serious spinal conditions that would exclude a patient from seeing a chiropractor. We would then come up with a diagnosis and a strategic plan of how to treat that in order to get that patient better as quickly as possible. So we have various techniques of spinal manipulation, exercise therapy and rehabilitation, modalities and ancillary procedures such as laser, IFC, ultrasound, nerve mobilization, also known as nerve flossing, taping and orthotics, discussion of work postures and how to improve those, lifestyle and nutrition education. So you can see we have an overflowing toolbox of conservative options, but we want those options to be evidence-based, and we have to recognize our limitations. So after a certain amount of visits or treatments, and we're not seeing the results that we need to or expect, we need to move that patient on to the next option. Next slide, please. Okay, next slide, please. Okay, so here's an interesting article from the Journal of Spine that indicates a 2010 systematic review found that most studies suggest spinal manipulation achieved equivalent or superior improvement in pain and function when compared with other commonly used interventions for short, intermediate, and long-term follow-up. I think it's important to note that when we're dealing with back pain and back and leg pain, that we're not just worried about pain, but also about function. It's often great to not just discuss and focus on pain, and that when we see patients improving their function, that's a good sign that the treatment that they're undergoing is useful. Next slide, please. So let's talk about some of the other common whys that may be hiding in plain sight that lead to back pain. So of course we have spinal structures that are pain sensitive and produce pain. But what about the muscles, the supporting structures around the spine that may also lead to dysfunction in posture and mechanics? So for the sake of this talk, we'll look at the bottom four boxes, and we're looking at something called lower cross syndrome, where we have muscles that are weak and we have other muscles that are tight. So for instance, in this particular case, we have a patient with weak gluteals, which are important hip extensors, and also weak abdominal or core muscles. And then mirroring that are tight hip flexors or psoas muscles, hamstrings, and as we all know, tight lower back muscles. So what happens is that these muscle imbalances, they lead to abnormal mechanics, poor spinal posture, some segments in the spine that don't move as well, and some in the spine that move more than perhaps they should. And you know, Dr. Finkelstein discussed some of those in his slide on Kirkcaldy-Willis. Next slide, please. Okay, so I thought it may be interesting if we just discuss a case that I saw recently in my office. We'll go through some of the symptoms that patient presented with, and then how we treated that in our office. So this gentleman came into our office. He was 44-year-old male with episodic back pain and left sciatic pain. He came in with x-rays from his family doctor, which were essentially normal. And he also had an MRI, which revealed mild to moderate disc protrusions at L2-3 and L4-5. He had some stenosis and also some degeneration in his spine. He had reduced painful flexion and extension in this case, a positive straight leg raise and a positive Valsalva, although his neuro exam was normal. He had no history of trauma and no other medical issues. He was 6 feet tall, 220 pounds, and had no red flags. So we went through his history and his health history, and we did an exam, and we had to consider, you know, the variables that led to him having this back pain. So this particular patient was a truck driver who was doing mostly sitting and driving, as well as frequent lifting when he had to unload his truck. He had a lot of pain in forward bending. He had off and on, this was an off and on problem that he'd struggled with for a few years. And he was very deconditioned and had a weak core. Okay, the next. So part of our exam uncovered this lower cross syndrome that we discussed previously, where he had very tight low back muscles and a very tight hip flexors, accompanied by weak gluteals and weak abdominals, which was not good for his spinal posture. It brought his pelvis and angled it forward and put increased pressure on the lower segments of his lumbar spine. Next. So what we needed to do was work on strengthening these gluteal muscles and also stretching the smaller external hip rotators. But what happens is when we're sitting a lot, these powerful glute muscles that help support our back tend to become very, very weak and, I would say deconditioned. So we needed to work on those glutes, stretch his hips. Next slide, please. There's his original presentation. So he had that left-sided back pain with the sciatic distribution down the left leg. Next slide, please. Okay, so the typical treatment approach. So how did we handle his recovery? So the first thing we did was we needed to educate him on the contributing factors of his back pain. So we had to talk to him about getting in shape and losing weight. We talked about how, his postures will affect what's going on with his disc dynamics. We talked to him about ergonomic training. We gave him proper lifting postures and how to lift properly, protecting the back. Also correct sitting postures and the use of a lumbar support in his trunk. Then in terms of his physical rehab, we dealt with unwinding the lower cross syndrome. We stretched his hip flexors and activated his glutes and strengthened his core, as well as gave him a home exercise prescription. We did some modalities for the inflammation and to just relax the muscle initially. We did some traction, decompression to the lumbar spine, which I'll talk a little bit more about in the coming slides. And we did some nerve flossing for the sciatic nerve. We did some chiropractic manipulation for the segments not moving as well in the thoracolumbar region and through the SI joint as well. And we stressed to the patient that their participation in their recovery is equally as important as any medical intervention. They're spending much more time on their own at home than they are in the office. So the more that they can do their home exercise prescription, the faster they could get better. So I think this patient was 10 visits, and we were able to discharge him to a home program, and he's been very good since then. So we'll go on now. I'd like to talk a little bit about spinal decompression because I'm seeing it as a very effective treatment for disc and leg pain together. Next slide. So we know that everyday pressures in the disc range from 100 to 300 millimeters of mercury, depending on whether you are sitting or standing. So we can see here in the next slide some of the pressures exerted on the disc by normal posture. So we can see that lying flat on the back is the least amount of pressure in the disc. Standing then increases that pressure. Standing and flexing forward with a weight increases it even more. And the greatest pressure on the discs of our lumbar spine is sitting, holding weight, and flexing forward. So those are some of the postures we need to try and avoid in our daily lives. Next slide, please. So how did spinal decompression therapy come about? Well, initially it was astronauts who were in space realized that when they were in space, their back pain went away, or their back pain combined with their leg pain went away. So doctors and researchers looked for a way to decrease the pressure in the disc, and it came to these specialized tables. Next slide, please. So a study published by the Journal of Neurosurgery, researchers placed a pressure sensor in a disc while undergoing decompression and found that the disc pressure dropped to minus 100 millimeters of mercury. Now, this negative pressure inside the disc drives in blood and nutrients, which the disc would not get otherwise. Next slide, please. Decompression typically treats herniated discs, degenerated discs, and the referred radicular pain that can often accompany that. facet syndrome, sciatica, and chronic neck and back pain. So what does a typical treatment with decompression involve? So a typical treatment takes 12 to about 30 minutes. It's a very comfortable and safe procedure. In fact, most patients don't really realize much has been done until after the treatment has been completed and the table returns to its original position. Treatment typically is every day for 2 weeks, so 5 days a week for 2 weeks, and then 3 times a week for 2 weeks. If the patient's pain resolves within that time, there's no need to continue with further treatments. Next slide, please. So conditions that may disqualify a patient from decompression therapy is pregnancy, cancer in the bones, abdominal aortic aneurysm, or surgical fusion. We always like to make sure that when we're seeing a patient for decompression, that their family physician is involved. They understand what the patient is being recommended for treatment, and if there are any contraindications to their patients receiving decompression therapy. A Mayo Clinic study on spinal decompression took a nice sample of patients whose average pain score was 6.4 out of 10 before they began treatment, and that they needed to have pain for more than 6 months. 20 treatments were given over the course of 6 weeks. Next slide, please. Okay, this study found that post-treatment, significant pain relief was found in 90% of patients. Average pain decreased from 6.4 to 0.8 out of 10, which is significant. They required fewer analgesics, which is pain medication after treatment, and that they found no safety issues or no adverse effects with spinal decompression. Next slide, please. Yeah. Longer-term results study showed that 91% resumed normal daily activities. Over 80% showed 50% or better pain reduction at the end of the 4-year study, and greater than 50% still had a pain level of 0, which when you have back pain combined with a radicular complaint is quite good. Next slide, please. So what is the big shareholders or the stakeholders saying about the overall clinical effectiveness of chiropractic treatment? So the FDA, the Food and Drug Administration, states that no non-pharmacological therapies, including chiropractic, should be used. Next. The Department of Defense, so the US military. Next, yeah, indicates a systematic review of more than 90 relevant studies concluded chiropractic management of common conditions for VA and military health system patients shows significant improvement and high levels of patient satisfaction. Next, please. The Joint Commission. The Joint Commission is the major health accreditation organization in the United States. State governments depend on the findings of the Joint Commission to determine insurance coverage through Medicare and Medicaid programs in the states. And they found that non-pharmacologic strategies, including chiropractic, have an expanding role in pain management for back pain. And the CDC, the Center for Disease Control, indicates non-pharmacologic therapy and non-opioid pharmacologic therapies are preferred for back pain patients. Thank you.
So thanks so much, Dr. Palmer. And I think rounding up the discussions from, I guess, non-surgical through surgical options will be Dr. Jeremy LaRouche. I think at last count, just for those interested, we have about 170 odd viewers as part of the seminar series this evening. So I guess obviously just to provide context in terms of who's sort of in our virtual audience tonight. So Dr. LaRouche, I guess over to you, and thank you for providing this update on common approaches as it relates to surgery, if necessary, for patients with low back related conditions.
Fantastic. Well, first of all, thank you very much for having me. I want to kind of echo my previous presenters' discussion that what I'm trying to show you is some of the common surgeries that we perform and why we perform them, but to reassure you that the majority of the time, a surgical intervention is not required. So the vast majority of the time, treatment with either a physiotherapist, a chiropractor, a pain specialist, or even just giving it time and doing some home exercise can get through the majority of back pain situations. It's rare that you would require one of these, but I want you to know what we are able to perform as surgeons and why we would do it. So what I thought I would do today is really just take a few minutes to show you some of the most common types of surgeries we do, what the surgery entails, and really what we're trying to achieve with each of those operations. So we'll proceed from some of the more simple surgical interventions to something more complex, and I'll try to leave enough time to be able to answer any questions that people may have at the end. So one of the most common things we see as a spine surgeon that we could really intervene for is a disc herniation. And an analogy that's often given to people is that your disc has kind of a tough fibrous outside called the annulus. And the inside, the nucleus pulposus, is a little more softer, a little more jelly-like. If you get a tear in the lining of the disc, sometimes part of the disc can herniate or squeeze out and cause an irritation of the nerve. So it's pinching the nerve here. People often present with symptoms called sciatica, whereby they say they have shooting pain down the back of their legs into their feet. They may have some numbness, and they may also have some weakness where they may not be able to move their ankle as well as they should, where they feel that their feet are dragging when they're walking, which is often what happens when you pinch a nerve. The way I like to explain this is I tell people that think of the nerves in the spine as the electrical system in your house. If you flip a switch to your house, the electricity is hardwired to go down a wire to one specific area of your house. And if you pinch a nerve, well, you're cutting off the electricity that goes to one specific muscle. So you might lose one reflex, you might have numbness in one area of your leg, and you might have weakness there. This is an example of a case I just did a couple nights ago. What I want to show you is this is an MRI of the spine, and this is the side view. So the belly button would be somewhere up here, and their rear end is somewhere back here. And the square things here are the bones that are the vertebral bodies, and in between each vertebral body is a disc. A normal disc looks like this. As Dr. Finkelstein said, you know, we start off with a lot of water in the disc, so this disc is well hydrated, it's white, it's nice and taut in the back, that it's not causing any compressions. These two discs here have a little more wear and tear. They're a little bit darker. There's a little bit of a bulge to them, which is a natural process of aging. What's not normal is down here at the level of L5S1. We can see that this disc is flatter, and there's disc material that is squeezed out back here, and this is actually a disc herniation. And what this is over here is the white is the fluid in which the nerves live in. These little strands are the nerves, and the nerves are clearly being pinched down here. So this is two different views that I want to show you. This is the view above the disc herniation, somewhere around here. All these little dots here are the nerves living in fluid freely, and that's where they're supposed to look like. And by the time we get down to the level of disc herniation down here, this whole thing here is actually a disc, which is kind of compressing the spine, the nerves themselves, and you can see the disc herniation right there. So the treatment for this is often, believe it or not, disc herniation will resolve on its own. In fact, about 80% disc herniations that are small go away on their own. But if you get to the point where you're having terrible nerve pain that's just not manageable, or you're starting to get a significant weakness in your legs, you may decide to undergo what's called the lumbar discectomy. It's a small operation where we often do this as day surgery. You come in the morning, you have your surgery, and you go home that same night. We shave a little bit of the bone away to allow us to access the spinal canal where the nerves live. We would move the nerve out of the way, and we'd shave down or pull away the part of the disc that's herniated to make this nice and flat. The reason that we tell people that as surgeons, we're often good for leg pain, not back pain, as you can see that we're not actually fixing the disc. Unfortunately, with even 2021 technology, there's no great way to get the disc to heal or regrow. What we're able to do, however, is decompress the nerve and provide a significant leg pain relief by removing the part of the disc that's herniated. Unfortunately, this doesn't always do much for back pain, where after surgery, people often come back and say, well, my back is still sore. And at that point, that's when we'll really encourage them to see their chiropractor or physiotherapist to try and provide some muscular strengthening and recovery in order to recover the other half of their concerns. So that was the first problem. The second problem I want to talk to you about, which Dr. Finkelstein hinted at, is what we call spinal stenosis. And spinal stenosis tends to happen as we get older and we get more arthritis in our back and wear and tear. And I tell people that think of your spinal canal as an apartment or a condo building downtown Toronto. So some people have a penthouse apartment and there's plenty of room. And even if a guest moves in for a little while, they won't really notice. And some people have a very narrow canal and they have the equivalent of like a bachelor's apartment, that even if a cat moves in, you'll know that there's somebody else in the apartment and there's no room for anybody. So spinal stenosis often happens with people that have smaller canals to begin with. In this example, what I want to show you is, this is another MRI. Again, the square things here are the building blocks or the bones called the vertebral bodies. The spinal cord is this black line here, and at the level of around L1, it becomes a bunch of nerves going down. And the white fluid here in front of the spinal cord is cerebrospinal fluid. As we get further down, we can see that there's a few people moving in. There's a little bit of fat here, called epidural adenomatous. There's a small disc bulge, but there's still a little bit of room. We get down here, things get a little tighter. And by the time we get here, there's such a choke point that there's no room for the nerves to breathe. And people often present with what's called claudication. And that's a fancy word for saying, if I stand for too long, or if I walk for too long, my legs start to burn and they give out. And the moment I sit down, the pain goes away within a few minutes. I stand up again and I get run into the same problem. So to give you an example of what it looks like from the top-down view is this level, we're looking at with this yellow line here. Again, these little dots are the nerves. And at here, we're still looking at a fairly capacious or wide open spinal canal where there's lots of room for the nerves to breathe. By the time I get to the level of the stenosis or the narrowing, all those nerves are living in this tiny little hole there, and they're being squeezed by a combination of some arthritis, a disc herniation, and even some of the ligaments that are around the spine are a little too thick and causing compression. The treatment for this is we often do what's called decompression surgery or a laminectomy. I just want to clarify that our version of decompression is a little bit different than we talk about decompressive in the realm of chiropractors. So when they do a decompression table, what they're trying to do is stretch out all of the discs that are bulging to provide a little more room for the canal. When we talk about decompression, I tell people that we're making your spine a convertible. We're actually shaving the roof off. We're taking off the bone to allow the spine to, the nerves to expand and breathe on a permanent basis, an ongoing basis. Once again, this type of surgery is very, very effective for leg pain. It might help a back pain a little bit, but it doesn't tend to cure the back pain. The reason I say that is if your knee wears out or if your hip wears out and you go see an orthopedic surgeon, you might be offered a hip replacement or a knee replacement. As spine surgeons, we don't really have a back replacement. It doesn't really exist. So we're limited into either decompressing the spine, which is what this is, or sometimes we can fuse part of the spine, which is stop it from moving, but we can't, as of today, replace it. One of the reasons you might need a spine fusion is if you develop what's called a spinal slip. So the fancy word for that is a spondylolisthesis. And often these are things that don't happen as a result of a single trauma. It's not a car accident that causes this. It's a repetitive injury where the bones fail, and they can start as young as being an adolescent when you still have a growth plate, which doesn't form properly, or it can happen because of arthritis, where all of a sudden, some of the joints aren't as functional as they used to be, and it allows the spine to slip in front of the other. So here's another MRI. You guys will get pretty good at reading them by the time we're done. And what I want you to pay attention on this one is, again, we're looking at the same view. These square things here are the bones. Everything lines up very well all the way till we get here. There's a little bit of a step deformity there. So when we label vertebral bodies, we say that there are 5 lumbar vertebral bodies. So this would be L4 and this would be L5. So we would call this an L4, L5 slip or spondylolisthesis. And the reason this particular slip has happened, because there are many different reasons it could happen, is because of some of the arthritis in the back has allowed the joints to be a little looser than they should be, and it's allowed this abnormal motion over time. So a spondylolisthesis can cause problems for more than one reason. And it can cause some narrowing of the canal, but it also causes a second problem where we get what's called foraminal narrowing. A foramen is basically the window by which each nerves exit at every level. And the problem was when you get a significant amount of disc collapse, I tell people it's kind of like Indiana Jones and the Temple of Doom. So if you remember that movie, there's a scene where all of a sudden they're stuck in the temple and the wall and the ceiling are getting closer and closer and closer together. And that's exactly what happens to the nerves here, is that as the disc collapses and there's a little bit of a slip, the space for the nerve to exit gets smaller and smaller and smaller to the point where the nerve is being trapped. So sometimes just doing a discectomy in this case isn't enough to relieve the pressure around the nerve. So what I want to show you is 2 examples of the MRI of someone who's got a slip. So in this first MRI, again, just to orient you, these are the bones, these big square blocks, and this is the nerve, the disc in between the 2 bones. And there's a little hole here that looks like a key-shaped hole. In the middle is the nerve at its exits, and around it is fat. The same way that you kind of have insulation around a copper wire, the nerves often have fat to protect them as they exit. In this case, on the right-hand side, again, there are the bones here, the vertebral bodies. This little squiggly line here is the nerve, and there's no room for it left whatsoever because this disc is collapsed. It's got a little bit of a slip, and there's a little bit of arthritis in the back. So this patient has not only some central stenosis, which is causing some compression of the nerves here, they also have foraminal stenosis, where because of the floor and the ceiling of this foramen have gotten so close together, the nerves are being pinched. So often, this is where you'll hear us refer to doing some type of a fusion procedure. One of the most common fusions we do is called a TLIF, stands for transforaminal lumbar interbody fusion. So essentially, we start off with a patient that's got a slip, the same one I showed you here. This is an L4-5 slip. We will start the first part of the surgery by doing a decompressive laminectomy. So again, that's making your spine convertible by removing the bone in the back. But that takes care of one of the problems, but not the narrowed foramen here. And then the third part of the procedure that we do is we'll actually put a metal cage where the disc used to be, and we'll put screws and rods above and below. Ultimately, what we're trying to do is make this level, the L4 level, and this level, the L5 level, one solid piece of bone. So we're really trying to get what we call a fusion across these 2 levels. The reason we worry about fusion is that anytime we put metal in the body, if you keep stressing a metal, for example, if you take a paper clip and you bend it hundreds of times, eventually the metal will fatigue, it will break. By getting bone to grow across where the disc used to be, the bone is a living substance which continuously regenerates itself, which means that eventually the screws and rods won't have any stress on them whatsoever because the bone will have fused and will be taken care of, preventing motion across the segment. Another question we often get is, what do we use for fusion? So the first spinal surgeries were done using your own bone. So we would often borrow bone from different parts of your body, sometimes your iliac crest, or sometimes from your spine itself, and we just try to get the bone to fuse by adding extra bone. The majority of the time today, we actually use metal implants, which are actually made of titanium. And the reason it's important is because people ask me saying, well, if I have a metal in me, that means I can never get another MRI. And because titanium is not ferromagnetic, which means it doesn't react to magnets, it's perfectly safe and you can still image it and get new MRIs in the future. It also doesn't beep when you go through airport security. And the metal is actually an empty cage. And I tell people the comparison I think of is, think of this as an empty condo building. It has all the right structures for cells to grow and move into it, but it starts off empty when we first put it in. Over the next 3 to 6 months, as you heal from your surgery, bone will actually go through all these little pores and go right through and end up inhabiting this entire space, allowing bone to go through the implant from one end to the other. So this is an example of a case I've done a couple of months ago. Again, what I want to highlight is these are x-rays as opposed to the MRI, but it shows that there's a slip where the L5 body is over here, the L4 body is slipped on top of it. And after surgery, we put 2 screws above, 2 screws below, and we put this metal cage in, which is like I showed you. And you can see that we've made this patient a little bit taller. So they've kind of grown by about 4 or 5 millimeters. And as a result, the foramen, which is a hole where the nerve exits, has been restored. And the Indiana Jones analogy I tell you is that all of a sudden the roof and the floor are apart. So there's room for the nerve to breathe, and which often helps a lot of the leg pain symptoms. The last thing I want to briefly talk about, because I know it's been a long night, it's some spinal deformity. This is less frequently done, and it tends to be bigger surgery, but it's one of the few times that we can operate on someone with a significant back pain and make them better. So one of the important things to realize, and Dr. Finkelstein hinted at it at the beginning, is we're not really designed to walk on 2 legs. Our spine is always fighting gravity at all times because your center of gravity is in front of the support structure. I tell people, if you're going to build a tower or a condo building, you want to put the center of gravity directly over top of the support. But in this case, we're always leaning forward. And the way our spine works then is the same way as a crane. We have to have a solid bony structure in the front that supports the front, but we also have to have these wires that are pulling in the back. So all these ligaments play a role. The problem is that we really have a small area of balance that we have to be within in order for our spines to function well. And if we fall outside of that spinal balance, we start having more pain, less function, higher risk of complications, and specifically with revision surgery. So I tell people that there's always this economy where you want to keep your head above your feet. And if you don't, well, you might be prone to having some unfortunate side effects of gravity. So as a result, when we look at someone, this is a patient that I've had a year and a half ago, which had a significant problem to the point where her back, instead of having a nice curve, was so flat that whenever she stood up, her head was so far in front of her feet that she would have the sensation of falling forward, and she required the use of a walker to be able to ambulate anywhere. She also had significant back pain because all of her muscles are trying to work overtime to try and pull her spine back up to be able to keep her center of gravity over her feet. So this is a rare occasion where we might have to do something more aggressive in terms of cutting out some of the bone of the spine to correct the deformity. And if you look at this one here, you can imagine if we cut out a wedge shape of bone and we put the two ends of bone back together, we'd get a very big correction, which is exactly what we did here. So we started off with a spine that was quite flat and very, very forward stooped posture. And if you look carefully here, there's that little cage that we talked about at the L5-S1 level. And the L3 vertebrae doesn't look like it has a square anymore. It looks like a triangle because we actually cut a wedge shape out of it, which allowed us to restore a nice curve. But this comes at the cost of a significant amount of range of motion because those rods and screws are going to prevent any range of motion from happening here. And therefore, we're left with a spine that has much less mobility, but better alignment. So that concludes my presentation. I'll turn it back to Dr. Yi to see if he can field any questions.
That's great. So thank you so much, Dr. LaRouche. And I think I love your analogies, and I think you also highlighted the thought process in many of us as healthcare providers of differentiating whether symptoms are arising from sort of mechanical wear and tear, aging, degenerative changes in the back, and are having more back symptoms, or I guess electrical circuit type of analogy in the home as it relates to maybe when there's pressure on nerves, the nerves are having symptoms and you're feeling those more in the legs, which is where those electrical circuits sort of supply those particular muscle groups and sensation areas. And so I sort of liken it to almost the Christmas tree analogy, where you have the sort of central trunk, which is your central spinal canal that you're making convertible out of to open up some space if necessary. And sometimes the branches that can get narrowed a little bit as well, as you talked about with some of your fusion techniques. And I think you highlighted quite well the aspect relating to sort of the occasional situations where there's gross imbalance, spinal balance that we often sometimes consider surgery for, which may help the back mechanics and related symptoms. So I guess with that, we'll segue to the question and answer period at this time. So I guess for those in virtual attendance in the audience, please use the chat button for additional questions that may arise. I'll probably use that as a bit of a cue in terms of a sense of the group in terms of when we've answered as many of the questions as we can this evening. Some of the questions I think that have been already raised and addressed to us previously have been answered, but I think it'd be nice to highlight some of those questions, and I think it covers some of the themes, important themes that we sort of spoke about this evening. So maybe I can ask the panelists to all unmute your microphone, and by all means, certainly participate in the discussions. You can ask questions of each other, and we'll try to facilitate as much of an interactive discussion period as possible, obviously within the logistics of our virtual framework. So I guess the first question, and Dr. LaRouche, you showed quite nicely some images, which maybe to some people that are not used to seeing it could be quite impressive. I think similarly, this question comes from an individual who's had an MRI report. They may not have the images, but the report. sort of reads L3-4, prominent disc bulge, severe facet arthritis, severe spinal canal stenosis causing cauda equina compression, severe foraminal stenosis, and basically a paragraph or so of things, or 2 paragraphs of descriptions of some of the severe structural changes that are happening. Basically this patient says, the doctor says, I don't present with this severity. I've got lower back pain, I can stand for about 10 to 15 minutes, and I get some relief when I'm sitting, and some non-surgical treatments are recommended, and you support this treatment. So I guess maybe you can comment on concordancy and how folks may interpret, obviously an MRI report or an X-ray report along those lines.
That's a great question. I tell people that I'm always careful about interpreting an MRI report, and that's often why when you see any of the surgeons, they'll often look at the image themselves. And there is some variability in interpretation. So if you look at a picture of the Mona Lisa, some people say, oh, she's smiling, some people say she's frowning. There's some variability in how people see those things. So when we look at MRIs, we'll often look at them ourselves to try and see exactly what we're seeing. There's also an interesting fact that some people can have a terribly arthritic looking spine and have no symptoms. Specifically, if the changes are taken on very gradually over years and years and years, the body's able to adapt and doesn't often present the same way. Conversely, they could be a very small disc herniation, but if it's right at the choke point, it can cause significant pain and symptoms. So I tell people that the challenge with getting an MRI, and Maria brought it up, which is important, is we don't want to MRI everybody out of the blue for preventative, because we'll start looking at a whole bunch of things that may not need any treatment whatsoever. As Dr. Palmer mentioned, I tell people that I'm more worried about the red flag symptoms as opposed to what the MRI shows. So if you have sudden change in bowel and bladder function, if you're getting a significant weakness in your lower extremities when you walk or stand, or if you're having a significant pain shooting down, even with a mild looking MRI, it still will be worthwhile to see a surgeon to have a conversation about what this could be.
Yeah. So thank you, for that. I guess the, I sort of use the analogy almost of, we both like photography and taking pictures, and, every year we take a picture ourselves. We all look a little bit year older, and likewise you take an MRI scan of us each year, and you'll get a report that probably lengthens each year. And it's obviously the correlation of what symptoms you may or may not have with some of the structural changes that may be present on the imaging. And I guess that's a nice segue to the next question that looks at treatment. And I think some of the questions alluded to, I think almost one of Maria's slide that talks about what the magic wand is. And so basically, here's a couple of questions that relate to that, and maybe I'll ask Dr. Finkelstein and Maria to comment initially. Basically, I've been told I have degenerative disc disease. What's the best way to live with this? What can we do to prevent worsening of the condition or reverse the condition that's occurring in the spine? Is this generally true that back problems ease or resolve with aging? So maybe I'll ask Dr. Finkelstein to start. Maybe Maria and the rest of the panelists can comment afterwards as well.
So one of the things I mentioned at the beginning is that it's really unfortunate that the term degenerative disc is given a disease. It's not a disease. And the word disease sort of has a connotation that it's bad, or, a disease is not good. Well, the only alternative to having degenerative discs is to not get any older. And that's not a good alternative. And so it's a fact of life. It's going to be a fact of getting older that you're going to have degeneration of the discs, just like you have degeneration of any other tissue. That's why hair goes gray. That's why wrinkles get on the skin. That's why you need to wear glasses as you get older. The body degenerates, and that's what happens. And it shouldn't be called degenerative disc disease. And I think that puts fear into people's minds. It gives a bit of misinformation, and don't think of it as a disease. So how do you prevent it? Well, there are ways to modify it. We know there are certain things that do promote degeneration, such as smoking. Smoking can lead to more quicker degeneration of the discs, as it can lead to changes in the collagen all over the body. Weight loss is another thing that can lead to more advanced degeneration, but also back pain in general due to the muscle imbalance that Dr. Palmer was talking about. When you have a lot of weight in front of your body, you have to use your forces of the back, like a lever, the way Dr. LaRouche had that crane, where you have a lot of anterior weight and mass. Your back muscles have to work more to hold you upright. So there are ways to improve your pain in general. That is to lose weight, to make sure the muscles are well conditioned, minimize the risk factors such as smoking, and recognize that, as Maria has said, that hurt does not equate to harm. We know that deconditioned muscles are painful muscles. As they have to work more to do their job, they get sore, but as they get more conditioned, they will become less painful. So as you get more active and as the muscles get more conditioned, there'll be less pain. But there has to be, but I'm not saying there has to be hurt, but hurt does not equate to harm. And sometimes you have to just stress those muscles to get them more conditioned, and eventually that pain will get better.
And I guess Maria, yeah.
Well, if I
Additional
can
comments?
just add something to the treatment. Yes, weight is important because it makes sense. Yes, it's not only the biomechanical load on the spine. The fact is, as Dr. Finkelstein said, that the spine functions the best when the center of gravity is between our hips. And when we have a belly, the center of gravity goes forward. So the back muscles have to counterforce this force and work overtime in a way. So it's important also to keep the general conditioning. It's good for your mood and for control of your pain. The recommendation is 30 minutes a day, 5 to 6 days per week. It's wise to choose an activity that you enjoy, otherwise you won't be doing it and wouldn't be consistent. The other thing is like the muscles that support the spine. Is every other muscles with every other kind of muscle with age. These muscles, they kind of atrophy, and if we don't exercise regularly, we don't maintain their strength, they become weak. The weaker they become, the kind of, if I have to explain it this way, when the muscles that support the back are strong, they take, in a way, they take off the load from these poor structures in the spine that degenerate with age. The muscles that support the spine are called core muscles. Some of them are like bells. They are around your stomach or belly. And they like, instead of having, what was the question, a supportive device, you have to make this muscle stronger. There are two big muscles in that function that actually use these core muscles as your own supportive belt device. So planks or like a pelvic stabilization exercises will be a good choice. Some of the muscles that support the spine are very close to the spine, multifidus, back extensors. So strengthening these muscles will also be beneficial. And muscles in the lower extremity, like the quad and glute muscles, are also part of the core. They support the core, so it's important to keep them strong as well. Even some of the muscles that support the spine are around the scapula, latissimus dorsi, and rhomboids. So upper extremity strengthening, scapular stabilization exercises will be also beneficial.
So one theme you're hearing about this is from, as Dr. Palmer mentioned, and as Maria's mentioning, all the therapy or treatment has to be or should be mainly active, not passive. And if you can imagine a weightlifter wanting to, clean and jerk 500 pounds, he's not going to do that unless he actively uses those muscles to build the strength up. Someone else can't do that for him. You're not going to improve the conditioning and strength of that muscle because of what someone else does to your muscle. those passive types of treatments may provide some temporary relief of some inflammation, but it's not going to create a long-term benefit that will prevent pain down the road. It's only for short-term relief. So that's the difference between active and passive treatment, and we really advocate active therapy and active treatment for any of these conditions.
I just want to add, we cannot explain why certain people have horrible X-ray radiological abnormalities on MRI or X-rays, but they don't have back pain. And there are others who just have minimal, but they have back pain. So maybe it's related to genetics, maybe it's lifestyle factors, who knows? At that point of time, we can answer this question, but we can affect that. We can't affect your genetics, but we can affect three things: your fitness, your weight, and your core strength. So these are the three major things that you have to work on. And of course, it's important. Stress has a big relationship with back pain. It's important, if you find that you have a lot of stressors in your life, to adopt some relaxation, meditation techniques and things like that. So these are the things we can address: weight, fitness, and core strength.
So that's very well said, and I think discussions have sort of highlighted a couple of important themes. A degenerating disc is just that. The disc is showing some physical signs of degeneration that may or may not be symptomatic. And I think Dr. Finkelstein talked about maybe not a disease, but basically wear and tear or aging related changes. And I guess just in the healthcare field, we tend to talk about degenerative disc disease, or basically maybe we should be using the nomenclature of people that we think are having symptoms that are arising from their degenerating disc, recognizing that it's not always a one-to-one relationship as the group has discussed. And so I guess maybe I can just wrap up this particular question, and so I may do the Wall Street Journal type of exercise and ask each of the panelists. And so what is the best treatment, recognizing that we're not going to necessarily prevent the progression of the degeneration, but a goal is obviously to try to minimize episodes that you may run into issues from that process. And so if you had to give top three treatments, what would it be? So Maria, what are your top three treatments? I guess you talked about
well, I already mentioned them. Yes, that there is evidence shows that there is no perfect exercise program. So if when they compare the different kind of exercises, they cannot consistently show in randomized controlled trials, especially, that confirm that any type of exercise is superior to the rest. So it's at this point of time, the thought is it's a combination of exercises. I offer the directional approach to exercise. It makes sense. Yes, we use the movement that relieves the pain as the offloading movement, and we start exercising in this direction. And of course, with add core strengthening and general aerobic conditioning to with general aerobic conditioning, the brain releases endorphins in the brain. It's the same like acupuncture, as it helps with the pain and the mood. So this is always a combination: core strengthening, directional preference exercises at the beginning, hands-on treatment also in the early stages, as I mentioned, and general aerobic conditioning, and maintaining your weight in general.
Okay, so thank you. So you've got weight loss, you've got core strength, and you've got directional preference exercises as your top three. How about Dr. Palmer?
Hi, Dr. Yee. Yes, I think I would echo some of what Maria said. I know we've talked about hurt versus harm, but when it comes to exercise and rehabilitation, we also have to differentiate pain versus discomfort. So somebody may be uncomfortable doing core exercises, but that doesn't mean that they're in pain or they're damaging tissues. I like to look at it in an individual approach, because everybody's so different and everybody's presenting with different comorbidities. They could have a hip issue with back pain. They could have an ankle or knee issue. So I try to be specific in what I'm prescribing for exercises. And also, if I could highlight one thing, a lot of people do planks and a lot of front and back exercises in single plane. I like to vary the plane and do, you know, side planks and, you know, transverse, coronal, combining different planes of motion to work on the core.
Yes, of course. Like even Stuart McGill's like core strengthening program that we usually recommend is a progressive program, and each exercise has 3 levels: beginner, intermediate, and advanced, and it's very useful. And of course, the exercise program is individualized according to the abilities and the symptoms of the patient. And that's the treating specialist, like is it a physiotherapist or chiro should determine that. And yes, it is safe to exercise with pain. As I mentioned, we can't wait. Action comes before improvement. So you can't wait. You have to be completely pain-free to exercise. That's where the guidance of the treating professional is important. There are no change. Like there were studies comparing people who exercise with pain versus people who exercise without back pain, and the outcomes weren't different. I mean, they were like comparable.
So Dr. Palmer, I think you've brought up a very, very important message in terms of individualized treatment, and it's very much, you know, depending on the presentation and a variety of patient and physical factors that you sort of consider. And I guess maybe to that point, just before I ask Dr. Finkelstein on his sort of top 3, as well as Dr. LaRouche, so I guess in your experience, you know, and the patient's presentation, recognizing that you talked about individualized and they present differently. I've had folks that have been referred, for example, to my surgical practice, and you know, obviously, you know, I'm looking at a very subgroup of individuals that have, for example, just not responded to any of the typical recommended treatments that we've had, and you know, certain things have worked and others have not. And so which ones are sort of, I guess, sort of potentially fast responders or responders that you've noticed that you think might, you know, benefit from more specific, let's say, active types of treatment, and others that may potentially benefit from manual or other decompression sort of strategies in your experience? I mean, some patients may present so acutely that they just wouldn't tolerate certain types of treatment that you've indicated by individualized care.
That's right. So yeah, it really depends on how they're presenting initially. I tend to find older patients have more difficulty tolerating exercise initially, and maybe better to stream into decompression. And then once their pain symptoms have reduced, then get them into the active flow. Young people tend to do better with exercise initially, combined with decompression therapy if they're having true sciatic or radicular symptomatology. And then sometimes, you know, it's amazing, as you know, you'll have patients in their 80s that are still more active than people in their 40s and can handle it. But generally it's, I would say, age and kind of their acute presentation, what their pain scale may be.
Thank you. I guess Dr. Finkelstein, your top 3?
Well, what I do is the main goal when someone comes with pain, we have to determine whether it's back or leg. You know, we're looking at it from a surgical approach and triaging the patient for a surgical problem versus a non-surgical problem. So it's very important to determine surgery indications, which is primary leg pain. And there's a few back dominant pains that need surgery, as Dr. LaRouche mentioned, but that is the main thing that we're doing. And then when you're talking about back pain, it is most important when someone comes to our office to make sure that they don't leave the office with a bad cause of back pain. And when I say that, a bad cause of back pain is having one of those red flags. You want to make sure that their cause of back pain isn't something that's related to cancer or infection or some other bad actor. So if you don't have a bad cause of back pain, you have a good cause of back pain. So I don't mean to be facetious in that any back pain is good, but it's a good cause of back pain not to have a cause such as a malignancy. So once we have made sure that there is a good cause of back pain, and this is a benign cause of back pain, what we can do is we can reassure them that this is not a serious condition, but it can be a condition that leads to some functional limitations, and there are ways to improve that. And the first thing is to understand that hurt does not equate to harm to begin with, and then direct them for the right education and for the right program. And that is where we have a team approach, where you would have someone like, the physiotherapist like Maria, or the chiropractor as Dr. Palmer, direct them into those types of avenues for conservative care. And then there's other avenues, as I mentioned, the semi-invasive avenues, which is the pain clinic, that can be a potential option. But again, as a surgeon, our goal is to educate, differentiate, and then direct to the right person for the management of back pain.
And I guess the thanks so much for that, Dr. Finkelstein. And I think before I get to Dr. LaRouche for his top three as well, that was also one of the questions that an individual sort of had in terms of best treatments, and they were asking specifically about analgesics. And so I haven't heard anybody mention medication specifically per se. So maybe maybe comment, maybe Dr. LaRouche, you can sort of pick it up and comment on the role of medications and what medications should be considered if you're going to consider medications.
Absolutely. So I think my top three would be quite simply three things. Number one is movement. So I think, like everybody says, I think that staying on the couch and ignoring your back is not going to help, but you need to be able to move to kind of get through some of the pain. My second M would be medication. And it's important to talk about what kind of medication. We don't typically use narcotics for back pain. And the reason is that it doesn't tend to provide a long-lasting benefit, and it has downsides to be used for a long time. So often we're talking about using anti-inflammatory, sometimes a muscle relaxant, and those can be used judiciously when and if required. And the last thing that we haven't really talked about, which is also important, specifically when we're dealing with more chronic pain, is also the mind. So some of my patients are sometimes surprised when I might suggest that they participate in cognitive behavioral therapy, or trying to find coping strategies or meditation to try and provide some pain relief as an adjunct to movement and medication. But often when we combine all three of those strategies together, we get to the point where we have something that's more efficacious than the sum of its parts.
And I guess there's some questions about topical creams or things as well, or anything topical that the group would consider or not.
Again, that would be, for acute, an acute management of an inflammation. And inflamed muscles, inflamed tissues, do have a lifespan. And like anything that has an acute flare-up, you can use anti-inflammatory medication, whether it's topical or orally, but that's a short-term relief. And it's really, I would not recommend that as a long-term treatment, because then it becomes more of a, it's not really, there's no inflammation on a chronic basis. And then it has more of a placebo type effect, or becomes more of a crutch type of effect. It doesn't have any real efficacy used on a long-term basis like that.
And what about anti-nerve medications, anti-neuritics? So these are the role for things like Lyrica, gabapentin. I mean, apart from anti-inflammatories, Tylenols, traditional painkillers.
So it's a great point. I think what I would also kind of echo is that I kind of break up back pain from leg pain separately. And the reason is that the cause is different. So back pain is often a chemical irritation or inflammation, which we use a lot of anti-inflammatories for, versus nerve pain, which is often more of a short circuit where the nerves are overacting or firing, even though there's no irritation. So the treatment for nerve pain is often different, and the medications that we use are often separate. So if you have both back pain and leg pain, don't be surprised if there's a recommendation for two different medications, because they often work differently.
And I guess maybe this question's for Maria and Philip. It asks about, I guess, bracing or belts or corsets, and you know, how do you think about that? Better to focus on core strength. I guess thoughts on the same.
Go ahead, Maria.
There is no evidence that supports use of belts. It's not evidence-based. Yes, people do it. As I said, like make your core strong enough to be on kind of belt and support.
Right.
Yeah,
I would
so
There are ways to progress for core strengthening. So there are exercises that are really easy and appropriate for initial stages when you have more pain, and gradually then you progress for the next steps and get to more complex and more difficult exercises. So I shouldn't be afraid of core strength. There are ways to start it in a very simple form. And this is this again will be you'll be taught this by your treating professional.
Dr. Palmer, did I interrupt? Sorry.
It's okay. I was just going to say that I think belts are more of a maybe a reminder to somebody initially that's rehabbing a back issue that they need to protect their back and use proper lifting techniques, as opposed to actually a belt being a crutch for strengthening your core or something along that line.
Yeah, so I think it's, you know, I usually mention use it very, very sparingly if necessary during acute phases. You really don't want to get into that vicious cycle where you become reliant on it, and basically it just aggravates the deconditioning cycle and doesn't enable you to really focus on that strengthening part.
Right.
Recognizing, I guess, in our audience that we also have not only patients and community members, but we also have other healthcare professionals. There's one question from our primary care community and physicians. And I guess I'll ask the group to think about this a little bit before responding. I may have a specific question, I guess, for Dr. LaRouche before I get to this one, but what's the one thing that you wish family doctors knew about back pain is the question. And I guess before I go there, I'll ask Dr. LaRouche, because it sort of came up in one of the other questions, and you didn't comment on it, and some people might ask you covered well why we might consider fusion surgery for select indications, and obviously a subset of folks where non-surgical treatments have not improved. We've got fabulous hip replacements with great results. We've got knee replacements which are also reasonably successful, and many of our conventional back operations have track records sort of similar to those of, for example, of the knees, at least based on some of the more recent evidence and literature coming out. And there are, I guess, back replacements, total disc replacements, you know, it may not be a comprehensive motion segment type of replacement. So maybe comment a little bit about that, because people may see that on the website and in discussions. What about back disc replacements? And along the same lines, one of the questions relates to injecting things in the disc. So there's been a variety of things that are out there, and how do you make sense of that?
Yeah, it's a great question. So let me start off addressing with the disc replacement. So there are different types of disc replacement whereby we'll, instead of trying to put a cage which allows bone to grow through and through, there's a implant that allows some motion. And the thought was, because one of the downsides of a fusion is if I stop one level from moving, well, the level above and below still have to work overtime, and there's a higher risk that they may wear out in the future. So we call that adjacent segment disease. So we thought that maybe if we allow some type of procedure that allows some motion, it may protect against the other levels of wearing out. So Dr. Finkelstein actually just finished doing a study where we looked at almost all the disc replacements for the neck done in Canada, or sorry, Ontario, I should say. And we looked over a long period of time, about 12 years. And surprisingly, unfortunately, we haven't found that they're any superior to a disc fusion. And part of the problem is that if we replace the disc in the front, you have to remember there's still two joints in the back that are moving called the facets. And if we're just taking care of one of the problems in the front and we're allowing motion at some very arthritic joints in the back, people often still have ongoing neck pain or ongoing difficulty with an arthritic joint that's grinding. So what I would tell you is that while it is available, and if you look especially in markets that are demand-based, based on paying for certain healthcare services, you may find that there's a lot more advertising for things like disc replacement. When we look at the evidence behind them, they're not so far more beneficial that we think it's worth the added risks. And so it's not a common procedure to be done in Canada overall, and that's probably the reason why. Same thing with disc injections. I think that there's some very exciting things that are being done in terms of using stem cells or other things to try and regrow some of the disc or regrow cartilage. And what I'll caution a lot of patients is that while they sometimes look really great initially in the lab or on a rat model, they don't always translate to what we want to see in humans. So while I'm very hopeful that maybe 20 years from now or 30 years from now, we'll have these great ability to regrow discs, it simply doesn't exist yet.
So thank you for that. And, I think, recognizing that, disc replacements and fusion surgeries, et cetera, the one piece really, particularly as people, some people consider disc replacements, the vast majority of situations are often multiple levels. So when the wear and tear sets in, it's not usually just sort of one level, and the more levels involved and the more joints involved, the more complex structurally the condition sort of becomes. Okay, I guess back to that question that I had. And so what would you like your family practitioner colleagues to know about back pain that they don't know already? Recognize that we don't have all the answers either. I guess Dr. Finkelstein, maybe start off for us.
Yeah. Can you hear me? Oh, yes.
Yes.
I think that the program in Ontario, which is the Isaac program, was good in theory, and it's probably working in that you want to educate the family physician on who needs surgery and who would need to be referred to a clinic that would triage for surgery, but also who needs imaging. Because I think that what happens is that imaging that is overdone and overused without an indication, it's a lot of unnecessary angst in patients, because the radiologist reads as Doctor, you said earlier, as you get older, the paragraphs get longer and longer and longer because there's more things that are being read by the radiologist abnormal. But in fact, they're not abnormal. They're just, the radiologist is paid to read what he sees, and it's up to the doctor to put it into clinical context. And so at the end of the day, the clinical context is what's important. You don't direct treatment because of what the MRI says. The MRI should only be used to support the clinical diagnosis or the supposition that's made from a history and physical examination. When it's done the other way, it leads to further testing. It leads to further basically unnecessary tests and really unsubstantiated diagnosis. So I think that the most important thing is to rationalize the use of MRIs and imaging, and to rule out the bad causes of back pain, like I said, as opposed to a good cause of back pain, and refer to the back clinics, or the Isaac or the REC clinics that have been developed when the right indication is there. The one problem with that is that it is more time consuming. It's much easier just to write a prescription, an MRI for a patient. But I think that's just not the best approach. And that's what I would want to see differently done in the primary care practice.
Okay, thank you. I guess, Maria, did you maybe want to comment on that as well? And I do agree with Dr. Finkelstein. I think there is an effort to try to optimize the triage and obviously to try to confine the imaging. It's a bit of a challenge, and we've obviously had some process and flow issues relating to that, just sort of recognizing the number of referrals that we need to manage and how best to treat everyone who is presenting with symptoms that would like help. So Maria, I guess your thoughts on...
My point was exactly what Dr. Finkelstein already explained, and my recommendation is for them to use more often the services of the Rapid Access or the Isaac Low Back Pain Clinic, because the program is there to support them. and help them treat their patients with low back pain. It will be good, of course, if they also the program also offers some teaching in that respect, which is very basic, but gives them enough information to be able to decipher between leg versus back dominant pain. And even if they don't consider referring to the rapid access low back pain clinic, at least they know what the indications for surgery, for referral for surgical treatment. Like it's a leg dominant, if there are no red flags, it's a leg dominant pain that is not amenable to conservative management.
And I guess for those that may not be as familiar, this is a provincial program, and I guess was expanded from the Isaacs. And so how does a patient or a family doctor refer patients, and where are they seen?
Now the referral process is through the family doctor only. So the family doctor needs to get the referral privileges. So there is a website that they can register, and it's just the requirement is that they go to the website. There is a video, 15 minutes video that they have to watch, and I think there is some kind of a test after that, 5 questions. And once they are done with that 15-minute with that process, they receive referral privileges within 48 hours.
And I guess those 15 minutes that our family practice colleagues will be spending.
So maybe that's what's holding them back, is too much time from there.
So would it be sort of similar to some of the concepts that we talked about tonight, or?
Yes, it's about back versus leg dominant and spinal stenosis. Some clinical questions there, like they're based on spinal stenosis, leg dominant pain. It's nothing earth-shattering.
Okay. Well, thank you. Okay, just recognizing we've got a couple of minutes before wrap up, I guess I'll ask Dr. Palmer and then LaRouche to sort of mention their pearls to our primary care colleagues.
Sure, I'll just quickly comment because Dr. Finkelstein and Maria have given us excellent answers. But I would say from a mechanical low back pain perspective, the research bears out that a multidisciplinary program is the best. And we keep data on all our patients that come into our clinic, the physiotherapist and I, and it details what condition that patient came in with and how long it took for that condition to resolve. And for mechanical low back pain, if you're not seeing changes in 7 to 8 visits, it's pretty significant changes in 7 to 8 visits, something's not right. Patient should be showing or demonstrating big improvements. It shouldn't be this ongoing diatribe of treatments and an ongoing therapy that doesn't change or doesn't help the patient. And also with leg pain, sciatica or stenosis, I would say 18 to 20 visits. If the patient isn't responding, they shouldn't be continuing to go just for the reason of going. They need to be triaged on to the next stage.
Excellent points. Thank you so much. I guess Dr. LaRouche.
I will acknowledge that it's a very difficult position to be in, to be a family doctor and have someone who keeps coming to you with ongoing back pain, and to try to be the person to reassure them to say, you don't need an MRI, you don't need to see a spine surgeon. So I totally understand. I think my biggest thing would be to make sure that they are aware of all the different options available to them. So there are ways to treat, as Dr. Finkelstein said, some mechanical back pain that's resistant to considered treatment. You might benefit from radiofrequency ablation, which is a procedure where they zap some of the nerves in your low back. You may benefit from cognitive behavioral therapy and having less stress and less muscle tension. You may need a different type of exercise that's more supervised and more active. And sometimes you just need to have a spine surgeon review the file to say, yes, you're doing right, everything's okay, there's nothing there. So what I would tell you is we're always happy to hear from you. It's sometimes hard to do over referral, but if you want to send an email or give us a quick call, I understand it's a very challenging situation to be in, and I think we should try to do our best to bring as much of an assistance as possible.
That's great. So thank you for that, Dr. LaRouche. Excellent comments, and I think it's been a great discussion. We're sort of right on time, just 8:29, and so I guess towards closing, I just wanted to sort of acknowledge all our speakers for really excellent presentations. I think it's been a valuable sort of discussion of what we know what we don't know, and how we sort of approach assessing individuals, and what sort of recommendations that we can provide to the community as well as our healthcare providers in ongoing care and triage of individuals who have symptoms, and that we're obviously trying to improve spinal health for. So I just wanted to thank the audience for spending time obviously with us this evening. This obviously initiative is very important to us, and so your feedback is most certainly welcome and appreciated. It helps us formulate and think about future topics and areas of interest, and so please take a few minutes of your time to complete the electronic evaluation form that's been provided. And there's a variety of other topics and that are already planned. So please visit the Sunnybrook website, www.sunnybrook.ca for that. And obviously during this time, I hope everyone continues to keep well and safe as we all continue to sort of navigate through our wave 2 together, and hopefully with vaccine on horizon and with ongoing efforts, we'll hopefully see some improvement with the condition and situation. And a special thanks also to Monica for all her help in organizing logistics for us this evening, and to Linda and the hospital board for supporting us in such a strong manner. Have a great evening, everyone, and bientôt.